All right, we should be good. Hey, folks, welcome in for this month's trauma run of the webinar series. Dr. Shirtliff will be mainly running this today. I'll be here in the background. As always, as questions come up, put them in either the chat or the Q&A, whatever works best for you. I will monitor it in the background as Dr. Shirtliff goes, and we'll pass along questions. But without further ado, I'll pass it off. We can go ahead and get started.
Hi, everyone. Really appreciate you making the time. Um, there has been a recent request to discuss burn care in the pre-hospital setting. Actually, that request came before a multi-casualty burn event on May 15th. And since that time, been sort of thinking this through and preparing the lecture. And I really just want to start by saying that this was an unbelievably, just an amazingly, there's no words really to describe the the effort, the cooperation, and I know y'all probably hate this, but the heroism, like the literal in every sense of the word heroism that was presented that day and was life saving for many people that were severely injured. There's there's no way to put any of all of this into words. I've tried and failed, so I made some notes about things that I really did want to make sure I said out loud. I think first, a moment of silence for those that were lost in this. And then, as a way of breaking that silence and coming to the present day, one of our first responders that was injured in this event, I have the privilege to take care of her in the ICU for what's now the third week that I've rotated through there. Um, I had a conversation with her today, and I asked, how would you feel if I spoke about your case with the EMS webinars? And she was like, "Hey, I listen to those. I'm listening to you for the past several months whenever I can." And her response really was, anything that I can do or give to help others learn. Uh, she wanted her case shared, pictures and all. She said, if it can be of any use to anyone, anywhere, I want that done. And also just to communicate her her deepest heartfelt gratitude to those that cared for her and got her to us. As you'll see from the case review, most of the very difficult initial life-saving measures in critical care were performed before she even got to the hospital, which is, you know, touches on the theme that I always try to make clear, that you really are all initiating critical care in the field, and that we are all cooperative along a spectrum of care that extends all the way from the time of injury to discharge. So I felt those things were necessary to say. Um, but the last thing is again, just on behalf of the trauma team, the burn team, the emergency department team, everybody that was here to care for these patients that came. Um, uh, again, our deepest gratitude and appreciation for serving alongside with all of you in the state of Maine. I think I have not yet seen um, just just a more unbelievable multidisciplinary, multi-agency EMS response. And so I I did want to say that. But before I ramble on too much, let's go to the cases and talk through some of pre-hospital burn care and some of the newer things that we are doing that is helping to advance burn care here at Maine Medical Center. So the learning objectives, we'll review and discuss pre-hospital trauma life support, burn management. We'll review some critical burn cases, just two. I want to leave a little bit of room for Joe at the end. And then we'll discuss some of the newer modes of critical care management and actually just surgical management of burns, both in the ICU and in the OR. So the first case is a 30s to 40-year-old female who was a first responder to a fire, and then due to a subsequent explosion, sustained 54% total body surface area flame burns with a significant inhalation injury while she was working on scene. On scene, the first agency to respond to get to her was able to establish a surgical airway in the field, saving her life. I wanted to also extend from our trauma surgeon who revised that cricothyroidotomy and tracheostomy. He was really blown away. He said, you know, it was absolutely perfect. It was perfect, perfect, perfect. He couldn't say anything other than how perfect it was. And he wanted to make sure that whoever it was that placed that cric knew that that was absolutely the right call and it was done with technical perfection. So, you know, again, another opportunity to show or to say how appreciative we are. But that was really the first life-saving intervention for this patient. She was initially transferred to the nearest hospital for stabilization, where they were able to establish IV access, arterial line, catheterization for hemodynamic monitoring, and begin the initial volume resuscitation. From that facility, she was transferred by fixed wing to Portland, where she was received by a local agency that got her to us here. During transport, and you see this with burns, especially in the initial resuscitative phase where really all you have available is fluid, that the inflammatory response and the subsequent hemodynamic depression due to that inflammatory response to a big burn pretty quickly outstrips the ability to put crystalloid into a body. And that's really kind of a theme here that really has sort of pushed burn care to advance just due to the inadequacy of crystalloid resuscitation, then also the downstream consequences of over resuscitation with crystalloid, which leads to a host of problems which can be life threatening. So she was what I would say as stable as she could have been when she presented, given the extent of the burn, the time frame from the burn injury, all of the transfers, all of those things, and the resuscitative fluids that were available. And and so you know, not an unexpected presentation with the instability. The patient was oxygenating well on minimal ventilator settings via I wrote tracheostomy was actually via the cric. She actually had really basically minimal ventilator support the FiO2 with 30% on the run sheet with not much PEEP and really is kind of amazing, like good tidal volumes, the whole thing. That Crike was very effective. Um, when she got to the trauma base, she went rapidly to the ICU, where resuscitation was continued, and we transitioned right away to a full plasma-based resuscitation, which I'll talk about here in a little bit. Um, as she continued to stabilize the right upper extremity circumferential burn, the swelling progressed, and it was a circumferential third degree, and so she lost pulses. Escharotomy was performed, pulses were reestablished, within a good time frame. She also had orbital compartment syndrome and had emergent lateral canthotomies for this. Probably sight saving, honestly. She was able to see for the first time this week, and that's been a really profound experience for her, and has helped her to kind of reassess and be able to really experience how far she's come. And as she's continuing to stabilize, she actually was resuscitated well enough to undergo an early excision the following day. And that's prior to the plasma-based resuscitation era, which is very new. That would have been unheard of. She still would have needed significant resuscitation with crystalline. It probably would have been the better part of 3 or 4 days before she could undergo an excision. But because we were able to transition rapidly to a plasma-based resuscitation, she was able to stabilize quickly, come off the vasopressors, and undergo an excision of the more severely burned areas. And that also, as we'll discuss here in a little bit, is it really instrumental in attenuating and quelling the really profound inflammatory response that comes with a burn greater than 20% TBSA. Hers was 54, so 3 times the 20%. You can imagine it's at least 3 times the inflammatory response. So these are some of the initial pictures. You can see this is on presentation here. You can see there's third degree burns around the mouth. This has all since been grafted with full thickness skin grafts. There is, and here's the tracheostomy with someone pinching it. Really, no significant blood loss from this either. Really, it was just a stroke of technical skill. Burns along the back of the right arm. Again, this ended up requiring an escharotomy. Bilateral lower extremities. This has all since been excised, and this has split thickness skin graft on it now. And currently, she's undergoing, the day-by-day hydrotherapy, dressing changes, and sort of the long haul that people go through when they're, above 50% TBSA burns. She's no longer requiring ventilator support when she's not having dressing changes, so she's able to cap the tracheostomy and speak, which is another huge move forward, and has remained has responded to treatment for infections, which are a given with a burn of this size, especially an inhalation injury. But we're basically transitioned back down to we've de-escalated to antibiotic monotherapy that's going to continue just to completion, but there is no evidence of burn sepsis or any of the more kind of scary sequelae of big burns. So she's as a whole doing about as well as anyone can with a burn of this magnitude. And so again, that is a credit to everyone that participated, not only in her care, but in the care of all of those that were injured on May 15th. This is an older case that Dr. Scholl brought to my attention, and wouldn't you know it, when I was looking through it, I happened to be the on-call burn attending when this gentleman presented. So it brought back some memories. He was a 40 to 60-year-old male who attempted self-immolation by an unknown accelerant, although it was noted that he smelled of gasoline when he came into the convenience store. Um, he he lit himself on fire and ran around the store, and was actually extinguished by the store staff. Um, when EMS presented, he was lying stripped to bare to his underwear with burns to his face, oropharynx, neck, chest, back, and all four extremities. He actually had removed his own clothing as he was running through this store. This is a person with really severe mental illness, um, bipolar disorder, and had borderline personality disorder, and had attempted suicide previously. Um, However, he was oxygenating okay, despite the burns to his face and his chest. And so I think this team's response was, let's get him to the hospital as rapidly as possible. They got him in a sheet stretcher. They covered his body with sterile burn sheets. There was noted in the run sheet that there were no suitable IV sites. Um, and we'll discuss one of the pearls from the protocol, that if you do have, a significant transport time and you need to begin the burn resuscitation in the field, then it is reasonable to place an IV through burn tissue if that is the only location that you can find. And so just to be clear on that, we'll never fault you for establishing IV access in somebody, especially if you're coming for first. If you can initiate a resuscitation in the field and have time to do that, then it is certainly warranted. Um, because when they get to us, we'll end up placing central lines, and oftentimes, there's no two ways about it. It has to go through burn tissue. So the patient was hemodynamically stable on arrival and oxygenating 100% on room air. He had remained normotensive throughout his resuscitation in the ED. As I was saying, we established right femoral central access and a left femoral arterial line, and initiated his resuscitation. This is several years ago, and so at this time, we were still not we still didn't have quite enough evidence to support plasma only resuscitation early. And so our protocol at that time was to start with crystalloid, and then if somebody demonstrated that they were poor responders to crystalloid, then we would transition to colloid rescue. So we would intermittently give fresh frozen plasma along with the crystalloid. Since that time now, we've established a new protocol, which I'll talk about in a little bit, where essentially we're going straight to FFP only. And what that does is it significantly limits several downstream consequences like ARDS, renal failure, overall volume overload. And so it's rapidly becoming the standard of care across the country, but we're one of the first centers to really embrace it. And I think that is due like almost entirely to Dr. Carter and Rose Payne's work, kind of at the head of the burn team. So anyway, he did develop hoarseness and edema in the upper airway as the burn evolved, and was intubated by RSI. His initial debridement, which was mechanical, and so that's something where we go to the quote unquote tank room, and the burn nurses They crank that heat in that room to about 97 degrees, and they remove all of the burned epidermis, and they clean the wound so that we can get a really definitive assessment about the extent of the burn and the depth of the burn. Um, and so that was done that night. And they applied gentamicin antibiotics to his face and neck in anticipation that maybe he had a corneal burn, although later on ophthalmology evaluated him, and they were there ended up not being any corneal burns, thankfully. We get involved ophthalmology for every burn with a TBSA greater than 25%. And so the following day, the burn tertiary survey which is the really definitive measure of defining exactly how extensive the burn is, was he had a 45% second and third degree TBSA. The field team, by using the protocol and had estimated 50%, so it was pretty much right on the money. So these were the burns after the debridement. You can see really extensive to the chest and back. Sometimes, these, if they start developing respiratory compromise, in other words, once they're on the ventilator, if they have increasing inspiratory pressures and they can't pull a significant volume, then we'll have to perform escharotomy on the chest itself to release that, because a circumferential third degree burn to the chest and back is, that is essentially has the same issue that that an arm would, where we do escharotomies. And by that I mean the skin is so tight and it continues to tighten, but then the underlying soft tissue is inflamed and wanting to swell. And so those two things restrict ventilatory mechanics. And it can be so profound that they can actually be failing on the ventilator. But these burns were mixed thickness enough to the extent that he never did require that, although he resuscitated well enough to undergo early excision. So you kind of wonder if it had been olden times where it was crystalloid only resuscitation, and we had worked out to about 3 or 4 days, if he wouldn't have at that point needed a chest escharotomy. Essentially, we make it into a shield. We make incisions here and here, and then along the mid-axillary lines, and then across the bottom of the abdomen. So basically separate this sort of whole shield of the front and allow the tissue to swell along those lines. Well, these were the arms. It's the hand, and you can kind of see that the redder burn probably is really sort of deep second degree, and then this whiter area, regardless of skin pigmentation, this whiter area is a third degree. And these are things we watch very closely, even if they aren't circumferential, to make sure that we have still intact pulses, and we still have an intact pulse exam in the hand or in the wrist. And so if we lose a radial pulse, then we open along this line here. We actually open the forearm compartment and the extensor compartment to fully release the soft tissues underneath and allow them to expand and restore blood flow. And so that's another pretty significant burn in the last several years. So let's talk about the protocol a little bit. In both cases really are exemplary implementations of these things. Clothing should be removed. High flow in any patient with respiratory distress or hemorrhagic shock, or an airway compromise, cricothyroidotomy. But in general, any shocky patient or somebody who's especially carbon monoxide exposure, you're really going to want to try to push as much oxygen into that patient as possible. Highest priority airway problems and major trauma. Oftentimes, trauma and burn come together. In these last two cases, uh, really not major trauma injuries, although with blast injuries and such, that certainly is possible. The first patient does have a blunt cerebrovascular injury with a artery with a vertebral artery dissection. That thankfully was a low enough grade that we treat that with aspirin alone to prevent clot formation or platelet aggregation where the vessel the lining is disrupted. And then we allow that to heal, and usually by about 4 weeks or so we repeat a CTA, and in general most of those grade 1 or 2 injuries are healed. um, just as an aside. But otherwise, neither of those cases had significant traumatic injuries. Um, Managed shock if present. So yeah, early IV access and really pushing volume is critical with these patients, especially if you have a longer transport time to definitive care. Cover the burn with dry dressing, sterile sheet, commercially prepared dry sheet dressing. Really, anything will do, but the cleaner the better. Request ALS for a host of things, all the kind of intuitive things, respiratory compromise, shock, severe burns. They all benefit from pain medication, resuscitation, and some from airway establishment. For the advanced EMT and paramedic, establishing venous access is critical. IV or IO, really anything that you can do. It's going to be difficult in some cases to place cardiac monitoring. Do what you can, the best you can. And if shock is present, definitely aggressive bolus in patients who are not in shock yet or are sort of more slowly evolving. These are your initial fluid rates for kids 6 and younger, 125 an hour. For kids 6 to 13 years, 250 an hour, and then 14-year-old or 500 an hour. This is a really solid protocol. It removes sort of the guesswork and the kind of mathematics, which are all changing anyway in terms of calculate Parkland formula and those types of things. And since we're moving in the hospital setting anyway, since we're moving away from crystalloid-based resuscitation, those equations really don't mean a whole lot anymore, for what that's worth. So these are really good rates for however long you're going to be in transport. And then again, they will have significant pain. So manage that via the universal protocol. So some of the pearls from the 2025 protocols. Anything greater than 10% body surface area, circumferential burns, airway involvement, genital burns, burns to hands or face, are significant and should be managed as such via the trauma guidelines in Green One. But basically, any of those patients should be coming to a burn center or the closest hospital that with an ICU and surgeons that can handle that. When you do calculate a TBSA, it's only the second and third degrees that count. That's sort of hard to determine in the field, especially with sloughed epidermis and usually the chaos that accompanies a severe burn. A rough estimation is fine in the field, just so we have a sense of what's coming. But like as you've seen in those other cases, we do multiple assessments and reassessments to like finally and clearly establish the exact TBSA. But again, as we're moving away from the Parkland formula, where the TBSA is a little bit less critical. In other words, like greater than 20%, let us know. About 50% say those things are helpful. So don't spend too much time trying to drill down to like, is it 43 or 44 type of thing. Um, a good way to estimate if remembering the percentages, which I still struggle with, like percentages for each body part, and they're different for adults than they are for kids, is take the patient's hand size. So that's 1%. And then use that to estimate the body surface area. So you take that patient's hand and you kind of imagine how many hands are in each burned area. Um, Clean, dry dressings are adequate. So anything. I mean, a lot of ambulances. I think most ambulances carry sheets specifically for burns. Sterile burn dressings are noted in most of the run sheets that I've looked through. But if you don't have that, anything that is clean and can cover the burn. And again, it's preferable to establish IV access through non-burn tissue, but really they need the resuscitation as soon as possible. So if you can establish access through burn tissue, that is the right way to manage. Um, it's interesting. We were already when this pearl was put in here, we are already realizing, like, we kind of have a problem with crystalloid based Parkland formula. We tend to over resuscitate. So um, really just go by the fixed resuscitation strategy. So if you go back to the last slide, that you have it right here, 125, 250, 500, and they double, six, for six or less, it's 125. The next, 7 years of life, it's 250, and then everyone else is 500. So, and that, you know, even if you're transporting, several hours, that is still a reasonable resuscitation volume and strategy. And again, maintaining body temperatures is really important because if you develop hypothermia in a burn patient, they already have an issue with lactic acidosis almost always. And so when you take hypothermia, lactic acidosis, the third arm of the lethal triad is coagulopathy. And we do see a fair amount of coagulopathy in bigger burns, regardless of how well or how perfectly managed the resuscitation is. It's almost like it can be an inevitability, and that's part and parcel of burn shock. Um, so just to kind of underscore the fact that keeping a patient warm is actually shutting down one arm of the lethal triad. Which again, if that's the first time you've heard of that, it's coagulopathy, lactic acidosis, or any acidosis from anything, and and hypothermia. Okay. And that's why we keep our ORs warm. That's why when we do dressing changes on big burns, we have the room temperature up so high. It's to so that we prevent hypothermia, because that can rapidly cause a hemorrhagic decompensation, where you can have spontaneous hemorrhage and almost trauma-induced coagulopathy, because they're cold and they're acidotic. um, Rule of nines is probably another pretty good way to think about it. And because everything is a multiple or a fraction of nine, this kind of is a little more straightforward, I think, than the hands. The only thing that trips you up, though, is that for kids, they have a difference between the head percentage and the body percentage. So if you look at an adult, back of the head's 4.5, front of the head's 4.5, the whole head itself 9. Great. The back is 18, the front is 18, 36. Done. Back of the arm's 4.5, front of the arm's 4.5, 9, 9. Back of the leg is 9, front of the leg is 9, so 18, 18. Easy on an adult. A kid, a little different. So the head is actually 18 in some. So the back of the head is 9, the front of the head is 9. So then they have to take it away from somewhere. So the back is a smaller contribution. It's actually 13, not 18. We calculate the buttocks separately, and then the legs are 7 because they're shorter in babies, and that's sort of how. But a rough idea based off of this is good enough for an early scene report to let us know what you're bringing and what you're taking care of. Any questions at this point, Joe?
Nope, nothing's come through so far.
Okay. Um, so we made it out of the trauma bay to the ICU for this is still going back to patient two. He was initiated on his initial resuscitation with crystalloid, and I remember talking with Damien about 2 hours into this. I'm like, hey, he's really not like this is seems like a waste of time. We should move to colloid first, and so we did, and then we went from there with multiple FFP rescues. He did have a refractory acidosis, and so the decision was made to proceed with early excision. So it's interesting because these two cases kind of bookend how far we've come. This case is about early, like essentially 4 or 5 years ago, and then case number one was this year, and so we still hadn't really firmly established the evidence that supports plasma-based resuscitation. And so we had to go stepwise from, okay, we're failing crystalloid, let's go to albumin. Okay, we're failing albumin, let's go to FFP. And so in that time frame, that patient's getting a ton of crystalloid and potentially over resuscitated, and then also isn't albumin is great, but it's very expensive and it doesn't contain kind of the special sauce that FFP does. So I want to talk a little bit about special sauce of FFP. So the we do have we were like of the we do have to establish criteria for what constitutes a difficult resuscitation, because that even if they're 20%, but they are doing fine on a little crystalloid and they don't evolve a big septic or inflammatory response, then they are not, they are a straightforward resuscitation and they maybe do not warrant plasma based. So there are some people that filter out of this. But these are some of our general rules of thumb. If the TBSA is 40 or greater, they're older than 65 years. If we keep increasing the infusion rate to keep up with urine output or hemodynamics, if the oliguria is persistent despite increasing the volume that we're giving, if they have refractory hypotension, again, despite volume resuscitation, so you're giving massive amounts of fluid. And I think we saw that in case one. Like it kind of didn't matter how much volume was given to that patient, she was going to be hypotensive until we switched over to a colloid-based resuscitation strategy. If the acidosis is refractory, so case number two, that was the case. Excuse me. Lactate continues to rise. Those two things usually come together. Inhalation injuries, they are really it, they amplify the burn, sometimes exponentially. There is, as you can imagine, if you're getting this massive inflammatory response to the skin burn, but when you burn the inside of the lungs are, really an organ that play that play a huge role in a systemic inflammation. There are factors that the lungs release that will inflame the entire body. So now, not only do you have burn inflammation, but now you've got inflammation happening at the level of the airway and into the lungs themselves. And so sometimes, we'll see, I mean, we will see people go absolutely off a cliff when they have a significant inhalation injury on top of a burn. In fact, sometimes we've had a few patients where they were 20% or less externally, but they had a severe inhalation injury and they needed the same levels of resuscitation that like a 60 or 70% burn would require. If that kind of makes any sense. So yeah, it's a massive inflammatory response to burns of the airway and lung. And then systemic poisoning as well is a reason to proceed with or to move to a plasma-based resuscitation strategy. This is our protocol. This doesn't project all that well, but this is our protocol that we use now. The initial rate, 500 milliliters LR, just like your protocol, right? So this is where EMS dovetails with the ICU right here. This is the plug-in. The patient goes, once they're stabilized in the trauma bay, they go straight to the tank room where their initial excision are taking off mechanically. This isn't, we're not actually cutting burn tissue off yet. We're just taking the dead epidermis off the surface to get a definitive sense of how big the burn actually is. We start aggressive nutrition right away because patients with burns have a really pronounced metabolic response to the burn itself. So you have to replace protein substrate. We call it nitrogen balance, but basically you have to get as much protein into that patient as possible as early as possible. And that's actually been shown to improve mortality and outcomes. So that's a given for every burn patient. They get high rate of tube feeds, and then when now just kind of turn more to the resuscitative part, we decrease our LR to about 100, and then we start adjusting with FFP. So this is what we use as our formula for giving FFP in the ICU. It's 1.5 milliliters times the TBSA ideal body weight over 16, and that tells us our rate. And so they're getting both. But if once you start with the plasma-based part, that significantly decreases how much LR that patient's going to receive. Then we adjust the FFP rate based on a nurse-driven protocol. Basically, this has to do with hemodynamics and urine output. In general, most of them meet their urine output goals. If you're doing this difficult, this is by definition a difficult resuscitation. It's a significant burn. If they don't respond to this, then it's almost a foregone conclusion that you will need dialysis. And so we'll start dialysis early. We'll go straight to CVVH if we have, after 3 consecutive hours of being on the plasma-based resuscitation, they are oliguric, because at that point they have the vast majority of these patients are going to progress to acute renal failure regardless. So earlier CVVH can help support the kidney early and get us back to a normalized renal function faster. And then eventually we just if you don't end up in this category, the patient goes this way. We slowly but surely decrease the FFP, and once we're off it, that's the end of the resuscitation. And then how we make decisions about whether that patient needs to be excised quickly has to do with really mostly their hemodynamics. So they're hypotensive. A lot of burn patients get hypotensive. And the question is, are they going to stay that way or not? Once we hit them with the resuscitation, if they're persistently hypotensive after we've initiated a plasma-based resuscitation, then we're really thinking this patient needs early excision. So they're bolused initially. We try to wean vasopressors. We don't bolus crystalloid, just colloid only. We repeat this, but if we cannot get off the vasopressors and we've given the requisite volume and we still have refractory acidosis, a rising lactate, that means this resuscitation is failing. You can do all of this perfectly, but if the burn is causing such significant inflammation that it's outstripping 1.5 milliliters per percent TBSA of FFP plus this, then it needs to come off. And it's really kind of amazing, when you see an early excision, you'll go from really unstable, requiring like at the bedside management in the ICU to like the next day, they're off vasopressors. They are, they're coming down on their volume requirements, and they're stabilizing. It's really kind of amazing when you get rid of the inciting cause of the injury, the underlying, you get what's, for want of a better term, source control of the burn. It acts in the same way as like source control for sepsis or hemorrhage control in a trauma. Here's some of the base. These are some of the outcoming sort of evidence that supports managing burns this way. This, as you can see, this is published 2025, so that's pretty recent. This was an American College of Surgeons publication challenging the legacy of resuscitation paradigms and fluid resuscitation with early plasma. Uh, this is basically saying like Parkland resuscitation strategy is done. It's been we've shown this method to be not only successful in minimizing post-burn sequela, but also has a survival benefit. And so once you say survival benefit when it comes to trauma, burn, or anything intensive care unit, then it becomes okay, this is what we need to be doing. And so this is sort of spreading throughout the country right now. Their initial hypothesis was that if you start resuscitation at a lower rate with TBSA with early plasma, that you end up with less fluid administration, superior clinical outcomes versus the Parkland formula. It was a retrospective comparative study, but it was weighted. There were a significant amount of patients, for like 200 plus patients or so. And this isn't actually like a full-on plasma resuscitation. This is with plasma rescue. So what they were really trying to establish was, can we give less crystalloid and rescue with FFP? And the answer was yes, in this study. And now since this, we've moved on to, we're going to do a plasma infusion along with the initial crystalloid and rapidly reduce how much people are getting. I mean, people used to get like liters an hour based off of Parkland of crystalloid, and now we're down to like 100 an hour plus the plasma. So you can kind of understand the scope of this. They looked at fluids administered, fluid volume, urine output, outcomes, and death. And these are their results, which are really pretty compelling, about as compelling as it gets. Mortality, mechanical ventilation, tracheostomy, hemodialysis were significantly less in the FFP group. So it seems pretty clear from this study, and there's multiple others with this that support this. Anyway, this was how the sea change started occurring. And again, also, despite less fluid administration, there was less dialysis, there was less acute kidney injury that did not require dialysis, along with mechanical ventilation, and patients were surviving. So, some of the other pieces of our protocol for early excision should be considered in any case of refractory shock, rising lactate, refractory acidosis, and failed resuscitation. We kind of went through that in the algorithm. The key, though, is you need them stable before you can do a subdermal excision, which means you're taking off burn tissue, like all the burn tissue. The initial tank room is rubbing off the epidermis. The next step is actually making an incision around the burn areas and separating that burn tissue off of the underlying fat. And it sounds like, hey, you're just cutting off skin, but the reality is that induces that can take a marginally stable patient and kill them. Removing tissue and the amount of blood loss that you can have with this, just again, you're taking someone who's already inflamed, and then you're giving them a surgical insult, which further inflames them. Those things can be life-threatening. So if you take an under-resuscitated patient to the OR and try to do an early excision, you can be in a rough spot. So that's part of how this plasma-based resuscitation strategy in the first 24 hours is really helping us to go to excision earlier, and to end to get source control earlier in the patient's course. And earlier source control leads to better outcomes, leads to better survival. So it's really kind of an amazing time to be a part of this. And so within our program, any burn greater than 20% gets a full excision within 72 hours. Ideally, the sooner the better. There's my references. Any questions?
Nothing in yet, but if people have questions at all about any of the burn care stuff, now's the time to ask. You can always ask after. We're always around and available, but
Yeah, feel free to
now's a great time to ask if you
feel
have.
free to email or whatever. I just did want to go back a little bit to some of the background as to why um, we think FFP works. Uh, there's been about a decade-ish investigation into the glycocalyx, and what is that, you may ask? Glycocalyx is like it's like a microscopic kelp bed formed of macromolecules of proteins and carbohydrates that sits on the the endothelium or the wall or the innermost lining of the blood vessels throughout the body. And what we do know is that the glycocalyx sort of gets effaced in shock, and in particular burn shock. And once that's gone, that's part of what allows all of the fluid creep and edema that necessitated more and more and more fluid to achieve stability. And so some very bright people, and I have to shout out to a guy who I know is probably not listening, but one of my mentors out at Davis was he's a MD PhD and actually a former defensive tackle for USC. He's had a he's had a very interesting life. Um, did some really kind of seminal work in this area to establish that actually FFP has the ability to stabilize the glycocalyx and prevent that sort of profound inflammatory response and the fluid egress out of the vascular compartment. And so, anyway, Dr. Brown, thank you for doing this. Actually, when I was at Davis, we were initiating some of our trauma resuscitations with FFP first as well, because again, in trauma, there's still a system. There's also a systemic inflammatory response to the injury that can become outsized and lead to trauma-induced coagulopathy and all the rest. So that was kind of the last point I sort of glossed over before. But yeah, if there's no questions, I just wanted to again extend our appreciation and gratitude. And thanks for making the time to listen. And if you have further questions, don't hesitate to send them my way.
Perfect. Thanks, Dr. Shirtliff. The evaluation link for today's session is in the chat. So if you don't mind, just take a click there. As always, give us the feedback. It also gives us space to put in if there are future topic requests and ideas there as well. A couple other nods. We're building a whole separate track. We're working on building a lecture series all just around all things toxicology with some of our colleagues from the New England Poison Center. So that'll come forward too at some point. The one piece to nod, but save us for today. Some of these burn folks, especially in like a house fire or an enclosed fire setting, make sure you're keeping in mind both carbon monoxide and cyanide are two of the pieces that you can make a big difference in the pre-hospital side. CO, really, it's high flow oxygen is the answer. Cyanide, if you have it and you have someone you're worried about hemodynamic collapse, you have the hydroxycobalamin in your cyano kit. Just remember you have both of those tools, but we'll get more about that in a separate forum. Let's see. One question, Dr. Shirtliff, that has trickled in says, question about moving a patient from an unsterile environment onto a stretcher. I don't know if that's just about how to keep the burns clean or the fact that the skin's so sensitive, but I think general patient movement from the scene setting and getting them to the hospital.
I think the priority for moving folks is if you have a concern about traumatic injury, then all of the things that we normally would do for trauma apply. Maintain inline stabilization, put a collar on, those types of things. Um, Beyond that, really just cover it and drive. I think the thing we wouldn't want to do would be to delay transfer to try to clean things, or because that again can make the patient cold. I think ideally you want to cover the burn and get that patient as warm as possible and initiate resuscitation. Those should be the three main priorities for taking care of a burn.
And then it looks like a follow-up. How should we lift a patient? A sheet and lift. I think it's going to depend from scene to scene.
Yeah,
Yes, that upper level of skin is going to be a little fragile, but at the end of the day, you got to be able to move this person. So if rolling them to get a sheet under
yeah.
them is going to be more involved. If you put them on a scoop board, I think whatever the logistics are, just like any other patient you were moving, I don't think there's any special must be extra cautious. Just
You'll get, yeah,
keep the
yeah. That's let me just kind of, I think I can kind of dispel a little bit of concern there. You're not going to hurt the tissue with positioning with even with the longboard or really anything. The tissue's already gone. So if a second degree is going to convert to a third degree, that happens over time, kind of regardless of what you do. And just bear in mind too that once they get here and we get them stabilized in the trauma bay, they're going to have everything cleaned and scraped off. So I guess not to, I wouldn't worry about the tissue. I know it's hard because you see a severe burn and it's you're looking at somebody that's been disfigured. This is and it's the skin. It's the first thing you see on somebody, and so it can be really kind of profound to see a severe burn. But just know that there's nothing you're going to do that's going to injure that tissue. It's already injured. The most important thing is to get the flames out if they're still burning, or get them safe. I hope that helps.
I think that addresses it. And then another question about normal saline versus LR for your fluid resuscitation from the pre-hospital side.
LR would be the fluid of choice. Um, yeah, LR. If you don't have anything but NS, do that. But LR would be preferred.
Yeah, it's a much more balanced crystalloid. It gives the
Yeah.
body more of what it needs, less of especially for folks who are going to have maybe a shocky or an acidosis picture. One of the things you run into with this, we get this from the sepsis side too. But normal saline, specifically with the chloride that's in it, when you're giving large volumes, you actually build up acidosis just from the amount of chloride you're giving also. So that LR, that more balanced crystalloid, is definitely going to be your better choice here.
One
But
of my
yeah, to Dr.
Well, I was going to say one of my favorite teaching points in the ICU is that the pH normal saline is 5.5. So you're giving an acidotic fluid to somebody who's already acidotic. So yeah, LR.
Perfect. I think that covers the questions we got here.
All right. Well, thank you all so much. Deepest appreciation, and talk to you next month.
All right. Have a great day, folks.